Hello everyone. Today I thought it would be a nice idea to talk about improvised peritoneal dialysis. I thought this was an appropriate topic because many of us live in low resource settings where it's not always possible to have access to conventional dialysis paraphernalia and peritoneal dialysis consumables, and yet we continue looking after critically ill patients, some of whom have acute renal failure. So it would be useful to know this information. And then the second reason is that during times of crisis, such as, for example, after a natural disaster like an earthquake, where we see an increase in crash victims that come in with AKI caused by rhabdomyolysis, or in a crisis such as the current COVID pandemic, we sometimes see a disruption to supply chains. And obviously, this means that we can no longer have access to peritoneal dialysis consumables, and this disrupts service. But if one knows how to provide improvised peritoneal dialysis, this need not be the case, at least for the patients with acute kidney injury. And then finally, for those of us who work with children, we know that oftentimes the only sort of consumables that are available to us are adult dialysis consumables, which may not be suitable for children, for particularly small children. And so if one knows how to perform improvised peritoneal dialysis, then one can still provide life-saving treatments to children, even smaller than normal children. So the objectives are to briefly review the principles of peritoneal dialysis, and then we just look at what options are available that one can use to provide dialysis in terms of peritoneal catheters and how to make one's own peritoneal dialysis fluids. So it's surprising that, we make such a fuss about dialysis, but really dialysis has been well described for over 100 years, was first described in the late 1800s by Thomas Graham as a process, and this Mr. Graham was studying the behavior of gases and the osmotic forces that are at play in fluids that are separated by semi-permeable membrane. And then after that, various people did studies in terms of the physiology of the membrane, the peritoneal membrane. Chiefly these were done in animals, and they noticed that when they instilled fluids into the peritoneal cavity of these various animals, depending on the concentration of solutes in the infused fluids, more fluid would be drawn out of the subject, or if the infused fluid was less concentrated, fluid would be absorbed, and many other things. So finally, in 1913, Patman actually published detailed work that he had done in dogs, characterizing the physiology of the peritoneal membrane and its use as a dialysis membrane. And then finally, we get Ganter in Germany in 1923, who performed the first successful peritoneal dialysis cycles in a lady who had cancer and improved her features of uremia. And then from then on, we begin to see further development of peritoneal dialysis, particularly after the development of the cuffed peritoneal catheters. I think it was in the 60s, and then from then on to where we are now, where we actually have commercially available fluids and we have specific catheters for use, and to a position where peritoneal dialysis is the preferred treatment in children, and definitely from an economic point of view is the most available dialysis treatment for children in low resource settings such as ours. So if one looks at the definition of dialysis by way of revision, we know that if we have two solutions, solution A and solution B, and these two solutions are separated by semi-permeable membrane, dialysis is the process that is responsible for altering the composition of solution A as it is exposed through this semi-permeable membrane to a solution B. So during this exposure, there are several mechanisms at play, some of which include diffusion, and I know that during diffusion, the speed of movement of molecules is determined by their concentration gradient. So molecules such as urea will diffuse or move by diffusion from the capillaries where they are in higher concentration into our infused dialysis fluid along that concentration gradient. Um, Other factors that influence the speed of diffusion are the size of the molecules. So we expect that smaller molecules such as potassium will move much faster than bigger molecules such as phosphate and creatinine. And then other mechanisms at play are ultrafiltration, which really defines the movement of water through these aqua porings that are available in the peritoneal membrane. And then finally, we also get absorption of fluid through the lymphatics. Those are the principal mechanisms that are responsible for movement of substances across the peritoneal membrane. So what are the advantages of peritoneal dialysis? Ideally, it should be the cheaper technique compared to hemodialysis. It's simple to perform. You don't need high-tech availability. It can be performed anywhere. It can be performed at the war front. It can be performed in a rural hospital without electricity. It can be used in patients with hemodynamic instability. And for those of us working in low-resource ICUs, it's important because many of the patients that we see with renal failure actually are coming in because they are septic, they have septic shock. And since we do not necessarily have everyday access to CVVHD, peritoneal dialysis can be used in such patients. And then finally, for those of us who work with children, we know what a hassle it is to get access to the big vessels, the interjugular vein, the femorals, and so on in very small children. And so obviously peritoneal dialysis, because the peritoneal cavity is bigger, provides easier access, allowing very quick provision of this life-saving treatment to children. Just a reminder of the usual indications for emergency dialysis in children, which we talked about in the lecture on AKI. Acidosis, that's resistant to medical treatment. We would dialyze patients with hyperkalemia, especially if they are beginning to see show changes in their ECG patterns. Patient with severe fluid overload, pulmonary edema, anasaka in anuric patients, patients who are uremic, they have encephalopathy, they may have uremic pericarditis, easy bleeding. Those patients need to receive emergency dialysis. Patients who are anuric, have renal failure, and yet require blood products in order to prevent the inadvertent development of hyperkalemia, and also to provide space for the volume that comes with blood products, we would provide dialysis. In patients who are anticipated to have acute kidney injury, which will be prolonged before recovery, we would dialyze them so that we allow them to have adequate calories, so to make room for nutrition. And then for those of you that are talking about hemodialysis, you may use hemodialysis for toxin removal. For example, if you have patients with neonates with hyperammonemia, urea cycle defects with very high levels of ammonia, which may be neurotoxic, you may perform CVVHD in those patients. So what are some of the contraindications that one might come across for performing peritoneal dialysis? Patients that have had recent surgery, patients with diaphragmatic injury, overlying soft tissue infection, or patients with severe respiratory failure. But to be quite honest, for those of us who work in low resource settings, these contraindications are relative because often the only mode of dialysis that is available to us is peritoneal dialysis. So we have often had to perform peritoneal dialysis in patients who are post-op and so have had recent abdominal surgery. We've often had patients with soft tissue infection in the abdominal wall, and yet we had nothing else that we could use, so therefore we used peritoneal dialysis. So given that we operate in these kinds of desperate conditions, again, I say these are relative contraindications. Severe respiratory failure, if you're lucky enough to have access to a ventilator, then you ventilate and then provide your peritoneal dialysis. You can try and reduce the fill volume to try and make sure that you don't splint the diaphragm. But essentially, use what you have where you are. Then I know that for you to be listening to this, you probably have had experience with providing conventional, proper, continuous ambulatory peritoneal dialysis. So we'll just go over what proper CAPD would entail. It would entail in children using acute catheters that are uncuffed when we anticipate that the renal failure will not be present for too long, just a couple of days. Use of cuffed Tencoff catheters when we anticipate that the acute renal failure will be there for prolonged periods of time. About 80% of our cases of acute kidney injury in the unit are secondary to malaria, and generally speaking, these patients require dialysis for between 14 to 21 days. So obviously for us, we tend to use more of the double cuffed Tencoff catheters. And then I'm sure you've seen that we use commercially manufactured fluids which are kept in sterile bags and so on. And the ideal situation is that these catheters be placed bedside, which is what we do in our unit. When Tencoff catheters are available, we'll place them under local anesthesia. When it's safe to provide sedation, we'll sedate the patients, but we place them bedside. So now we're here talking about improvised peritoneal dialysis. What that means is that these things that we have listed are not available. So then what do? Do you watch somebody die from renal failure? Obviously not. At least in our unit, we prefer not to just look at people dying from something that can be treated. So what are the options? So let's start with looking at how we can improvise in terms of catheters. When you cannot access a proper peritoneal dialysis catheter, you can use, first thing which we use in our unit is a nasogastric tube. So as you can see, I think this is a size 18 French. It's got that maroon tip, not tip, but cover, nasogastric tube. So what we do is at the tip of this NG tube, we would create extra hose to make sure that we allow optimal drainage of fluid from the peritoneal cavity. And then from experience, size 16 French works very well for most children. For very small kids, infants, preemies, one would use a size 14 nasogastric tube. For bigger kids, I actually find that the size 18 nasogastric tube allows us to add an adapter much easier. I'll show you what I mean on the next slide. I have had colleagues that have used hemodialysis, adult hemodialysis catheters placed into the abdomens of infants, particularly neonates, and then use one hub as for inflow and the other hub as drainage. And if you are lucky enough to have a burette, you can actually attach your fluids and give through a burette so that you can more accurately measure the amount of fill volume and also be able to accurately measure the outflow and therefore calculate the ultrafiltrate. There are also descriptions of colleagues that have access to chest drains and have used these as improvised catheters. I've seen reports from colleagues who've used conventional suprapubic bladder catheters with trocars and then just convert these into improvised peritoneal dialysis catheters. So essentially, as long as you have a tube, you can probably use it to provide improvised. In terms of insertion, when we are using tank of catheters, as you know, we would, as physicians, do this bedside in an emergency. We wouldn't necessarily wait for our surgeons. We do it bedside using the Seldinger technique. But when we use in our unit the nasogastric tubes, we ask our colleagues from pediatric surgery to come and place the nasogastric tubes. As usual, these are placed about 2 centimeters below the umbilicus in the midline, and then what they do is that they cut through the skin and then dissect up to the sheath. Once they get to the sheath, they cut through the sheath and identify the peritoneum, then cut through the peritoneum, and using forceps, they gently guide the tip of the catheter into the pelvis. Ideally, we want that tip of the catheter to be below the level of the superior pubic symphysis, just to make sure that once we start dialysis, we get good drainage. And I think this is the critical part. Often patients in whom we are doing improvised peritoneal dialysis are gravely ill. They are critically ill children, and really there's no room for error. And so this is the area that should be emphasized, that the tip should really be in the pelvis, so that once the dialysis starts, then it will function, we'll be able to infuse, and we'll also be able to drain out fluid. And then the other thing is, because the nasogastric tube does not have a cuff as indicated in this picture, usually our pediatric surgeons would then tie using a purse string kind of suture at the exit site, at the entry point where the catheter is going in. Use a purse string to secure it so that the tubing does not come out of the patient and disrupt this life-giving procedure. In terms of the extension tubing and improvised adapter, it depends what sort of consumables you have available. So if we're talking about you don't have fluids, you don't have any adapters, you don't have any catheters, then you can use as an adapter a 3-way tap, which is what is shown up there. That's a 3-way tap, and then connect the 3-way tap to the nasogastric tube, which is coming from the patient, and then use one hub for inflow of fluid. I say, if you're lucky enough to have a bureta, you can connect your fluids, your improvised fluids, to the bureta before it comes to the 3-way tap, and then use the other hub for drainage. If you can sort of use another bureta so that you can accurately measure the outflow, please do so, and then connect it to a fluid collecting bag. So that is one way. So after you've inserted the catheter into the patient, you attach this 3-way tap, which will allow you to use conventional IV tubing to deliver your improvised fluids to the patient through one hub, and then to drain the fluid through the 3rd hub. The second way is what we do sometimes on the unit when we have conventional peritoneal dialysis fluids. So here, what we're doing is that you can see the orange tip there. That's a size 16 nasogastric tube, and you just sort of force it onto the conventional. This is a Fresenius fluid bag for CAPD. You sort of just push it in. It's kind of hard, but you use a little bit of force to push it through and it holds. You may get a little bit of leak initially, but by the time you're changing to your second bag, we find that it fits in very snugly. So this is what we use. If you have a conventional double Luer lock extension, you can add the Luer lock extension using the same method, ram it into the nasogastric tube, and then use the conventional Luer lock to connect to the Fresenius bag, and then proceed with your dialysis. So the advantage of adding the conventional double Luer lock extension is that it allows the space for the patient to maneuver. If you do it directly on the nasogastric tube, the tubing is quite short, and the risk is that when the patient moves, because the nasogastric tube is secured by that purse string, the tube will just be yanked out of the abdomen. So we have to take extra measures to tape down the tubing so that it doesn't come out by accident. Now, coming to improvised fluid. So this is from, and we use this formula. This is from a colleague in Nigeria. Essentially, how to make improvised 1.5% and 2.5%. You need to start with Ringer's lactate. So you get a 500 ml of Ringer's lactate. If you're making 1.5% fluid, you remove 17.5 ml from that bag. And by the way, this has to be done in a sterile way. So put on sterile gloves, create a sterile field, put on a face mask, and make sure that you get an assistant to help you so that all these solutions are kept sterile. If your pharmacy has a hood that allows them to prepare sterile solutions for you, then the pharmacist can do it for you. So as I was saying, for 1.5%, you will remove 17.5 ml of Ringer's lactate from a 500 ml Ringer's lactated bag, and then we're going to add 50% dextrose, 12.5 ml, and then add 5 ml of 8.4% sodium bicarbonate. And then for the 2.5, to create 2.5, we remove 30 ml of the Ringer's lactate from the 500 Ringer's lactate bag, and then we'll add 25 ml of 50% dextrose, as well as 5 ml of 8.4% sodium bicarbonate. Okay. If you look at other papers, certain colleagues also add calcium to the solution, but we tend not to add any calcium gluconate. So what can go wrong with this setup? Well, the first thing, just like with conventional peritoneal dialysis, is infection. So as usual, we'll use aseptic technique when the tubing is being inserted to make sure that there's no infection introduced into the peritoneum. The second thing is we give prophylactic ceftriaxone before the insertion. And then again, because the tubing is not, it's not a closed system, the risk of infection from experience is almost everyone will get infection, but we've never lost a patient to peritonitis. Many of our patients that receive this sort of treatment are given intraperitoneal antibiotics, and we're able to support them until the renal failure resolves. So the topmost thing is infection. So you look at the effluent, checking to see whether it's becoming cloudy, is the patient developing fever, is the patient developing abdominal discomfort, diarrhea. As you know, those are the signs of peritonitis, PD-associated peritonitis. The second thing, as I had said earlier, is the tube dislodging. We're dealing with children. It may be difficult for them to keep still, and so the tubing may be yanked out of the abdomen. You don't want for this to happen in the initial 48 hours when the patient has metabolic derangement. So as I said, for us, we tape down the tubing so that even if the patient moves unexpectedly, the tubing will still sort of secure the tube. Often, the second most common complication is blocked tubing. So we find that the tubing becomes blocked either and most commonly by omentum, and so we have to keep calling our poor surgical colleagues to come and reinsert the tubing. And the second is blockage by blood clots, but for that you can, in a sterile manner, add heparin to the to your improvised fluid to prevent blood clots from clotting your system. The tubing may also become misplaced or migrate, so the tip will move from the peritoneal from the pelvis into the abdomen, and when that happens, you'll be able to infuse fluid, but fluid will not be able to drain out of the abdomen. To avoid that, we make sure that all of our patients who are on peritoneal dialysis receive lactulose to prevent constipation, because as you know, constipation is one of those things that make it more likely that the tubing will migrate from the pelvis into the abdomen. And then the fifth problem is the risk of trauma at the point when the tubing is being inserted. This is a risk that is present even when you are doing insertion using the Seldinger technique. You're worried about perforation of the bowel, you're worried about perforation of the bladder, so we make sure that we insert a Foley's catheter into the bladder before the insertion. You are afraid of bleeding as well during the insertion. So those are the complications that are possible with this procedure. These are some of the references, if you care to look at them. Please, if you use any other method of improvised peritoneal dialysis, please feel free to write something in the comments box. Let us know what your experience of improvised peritoneal dialysis has been. Thank you so much for taking time to listen to this talk.